today's didactic is being presented by Dr. D.L. Snyder, and it's on understanding addiction as a chronic condition. Dr. Snyder specializes in general psychiatry. His medical interests and expertise include psychiatry and neurology. As the director of the Mount Desert Island Behavioral Health Center, he oversees the MDI Hospital Penn Medicine Psychiatry Program, which brings residents from Penn Medicine to MDI Hospital each summer to practice on the island under his guidance. We're also very excited and happy that we have him as part of this ECHO. So I will turn it over to you, Dr. Snyder, and Jonathan, I believe, will be sharing your slides for you in just a moment.
Hopefully you can all hear me.
We can.
And that is the topic, understanding addiction as a chronic condition. And I think all of us probably on the call here today are very aware that opioid use, substance use disorder is a chronic condition, and it's very much like diabetes, hypertension, depression. And so we're just going to go through some of the reasons that opioid use disorder may have more stigma attached to it. And so if I could have the next slide and the next one after that. Yeah, I think I'm just going to leave that up there, but just why is it that this chronic relapsing illness of opioid substance use disorder has more heat and is more stigmatized than some of the other chronic relapsing medical illnesses that we have? And a little bit of statistics, it was sort of published in 2018 that there were 4.2 million Americans who had the opioid use disorder diagnosis. Of that 4.2 million, only 1.2 million received medication-assisted treatment. And this included those who were getting methadone, which is the full agonist, and buprenorphine, which is the partial agonist, or Suboxone, and also included the naltrexone, or it's sometimes known as Vivitrol. Now, if less than a third of the patients with the opioid use disorder received MAT, despite all the current scientific evidence we have that it reduces opioid use, that it improves retention and treatment programs, that it reduces the risk of relapse and overdose, and that it improves job functioning and family life quality. Why is it that everyone isn't sort of really behind pushing and supporting MAT? And I think we have to talk a little bit about why the stigma's here. And part of that is that most of the heavy lifting in treatment in previous decades was done by abstinence-based treatment programs. And those people got better, who are running those now, by an abstinence model. And so they believe that the abstinence model is best. And I think they can't quite help the fact that they sort of feel that using medication-assisted treatment is replacing one addiction with another. MAT patients who get Suboxone and methadone and the Vivitrol, they also say that a lot of their people who've been rooting for them, family members and people they work with who know they have the problem, even when they're in the medication-assisted treatment model, they keep saying, well, when are you going to get off it? And so it's just not viewed the same as it is with depression or diabetes or hypertension, where most people realize it's a condition that they may have to be treating and possibly medicating all of their life. One other issue with stigma is that our treaters, and I'll speak for the physician group because that's the training I had to go through, were trained in large urban hospitals, and our view of the opioid dependent patient is usually the chronic methadone treated patient who is not getting well or who has collapsed on the street, comes into the emergency room, and then ends up in the hospital. And so we don't get a chance to see those patients who actually get better and are really well treated by the MAT programs. Back in the 70s, when the methadone treatment program started, it seemed like they had a good rationale. They said, let's put the clinic where most of the patients are. But what that really did was isolate it away from the medical school and the people in training so that they didn't often see the good work that was done. So those are the reasons I think we have stigma existing. And what is it that we can do to fight stigma? And I think most of us agree that education is what counters stigma, and we overcome it with a willingness to listen and to educate others. And so that brings us to this quote that's been in front of you here. It's not a new one. It was written back in 1660, and it's by one of my favorite oldies, Blaise Pascal. Most of you, if you've heard of him at all, know his quote that the heart has reason the mind knows not of. He was the one that debated Rene Descartes that the body wasn't really a machine, and that he kept asking for, let's look at people more holistically rather than more mechanistically. But this quote, I think, is really the start of the whole idea of motivational interviewing. And I think most people realize that if you're going to try to overcome a stigma with a chronic disease, you need to look at this with motivational interviewing techniques. But what he said way back in 1660 was, people are generally better persuaded by the reasons which they have themselves discovered than by those which have come into the minds of others. And I certainly, as a practicing physician, know that what I say is much less important than what that patient is thinking and what they say they're willing to do. So with that in mind, let's just remember that all chronic illnesses, I'll take the next slide, are probably best approached with this motivational interviewing. People say it's something new, but as you can see, we've known about this for a long, long time. And they say there are 5 stages in this model. And think about your patients that might have opioid use disorder. And I'm sure you can have some in each of these categories, or you have talked to patients who are in them. There's the pre-contemplative phase where you're not thinking about making any change in the near future. That just, we talk about that being a patient in denial, but doesn't it sound nicer if you say to the patient, oh, it seems like you're in the pre-contemplative stage of changing or acknowledging this problem or illness that you have. The second phase is contemplation. They're actually thinking about making a change in the future. The next one is preparation, getting ready to make the change in the next month. Then there's the action phase in the process of making that change. And then there's the maintenance, maintaining the change made in an effort to prevent falling back into that targeted behavior or those symptoms of the chronic illness. If we'll look at the next slide, it probably is very small, and I apologize for that. But I'm glad we got the slide deck there. You'll start up at the pre-contemplative. That's where everyone is before they acknowledge a problem and want to do something about it. Then we go into the contemplative, and let's just talk about our substance use patients. And they can see that there's this substance they're using is causing them at least as much problem as it is helping them. And so they go into the preparation stage and then into the action stage, and hopefully they have some success, although you'll see the arrow does definitely, you can go from action back to relapse. We've all had patients that do that with all of our illnesses. And, but if you are able to go on to maintenance, we know that that is a very rewarding place to be, both for the patient and for the treatment team. And we love to have patients there, and some of them do move right on to termination. They are over this problem and they're done, but others do go back into relapse. And we should acknowledge that with opioid use disorder, you have two choices coming out of relapse. You don't necessarily have to go back to the contemplative phase of thinking about this, but because the primary mechanism of defense for these patients with substance use problems is denial, that they can also go right back up to pre-contemplation. So keeping that in mind, let's take a look at another chronic disease that I'm very familiar with. The next slide, please. And that's depression. And over half of our patients here at the Behavioral Health Center suffer from this diagnosis. I think all of you out there have patients with depression, or you're treating part of treatment teams that are treating depression. And it's amazing how, you know, there used to be a lot of stigma about having depression. I'm old enough to remember back when a vice presidential candidate was derided for having had treatment for depression, and there were those that questioned whether he could be fit for office. And so in one way, looking at that, it makes me hopeful that perhaps 10, 20 years in the future, there will be no more stigma about medication-assisted treatment for opioid use disorder than we have now for depression. And again, when you look at this depression, center of the photo there, change in brain chemicals and altered perceptions, that's exactly what we see with any substance use disorder, and certainly what we see with opioid use disorder. And you can see the stressors can be medical illness, work, family, financial problems. You know, there are physical factors, pain, low energy, poor concentration, poor sleep, alcohol, other drug use, behavioral problems with withdrawal, decreased activities, decreased productivity, and thoughts and feelings, negative thoughts, low self-esteem, sadness, and hopelessness. And I think what we want to just recognize from this slide is this is the human condition. This is how people hurt. This is why people come for health care. And so if we can just expand our thought process a bit to see that people who have opioid use disorder are just one group within a group of humans who are hoping to get better from the symptoms that they're feeling. So if you will, let me move on to the next slide then. And you know, those of us that treat depression day in and day out, we don't expect a patient to either be depressed or not be depressed. I think all too often the substance using patient, especially the opioid using patient, they're faced with practitioners and family members that sort of think they're either using or they're not using. But you know, in depression, when we treat that, we don't necessarily expect they're either depressed or they're not depressed. When we did the big studies, and we'll take a look at some of those results just briefly, in treating depression, we have various categories. We say there's a response. Well, we have lots of treatments available. We use medications. We recommend the counseling and talking therapies as well. And some patients like one, some patients like the other. And again, that's why our patients with a substance use disorder, we should give them a choice of the full spectrum of treatments. Some might like the abstinence models. Some might like just the counseling models, and some might like both counseling and medication-assisted treatment. But in the depressive chronic illness, we actually feel good if we can get a 50% reduction in their measured severity from different scales. And they mention here the Montgomery-Asberg Depression Rating Scale. That's the one used in these studies. And remission of the depression is when they have at least 3 weeks of absence of both the sad mood and the reduced interest, and no more than 3 of the remaining symptoms. There are a lot of symptoms listed in the DSM-5 for a major depressive episode. So you don't have to be completely free of depressive elements. And so again, if we think about opioid use disorder, let's not expect a person to be completely free of their urges or some of their bad habits, but are they not using anything except what is being prescribed? And then we also, when we treat depression, we're always looking for relapse. We know there's a reemergence of significant depressive symptoms and a return in the vulnerable period immediately following. I'm sorry, I'm reading from the wrong line. We do know that there can be the relapse, and that's when there's a significant increase in the depressive symptoms in that vulnerable period immediately following remission. We also have a term we call recurrence, and that's when the major depressive episode happens after there's been a recovery period. And again, we can think about this being part of the course for our opioid addicted patients as well. And then there's a recovery phase, an extended period of remission. And isn't it interesting that in our field of psychiatry, we define that as only needing to be 4 months when they have not had the symptoms. And so how many times have we been treating opioid dependent patients, and maybe they have a good 4 months, but it's not like we think of them as having had a recovery. What we see is the relapse and the recurrence. So if I could have the next slide. This is really just to share with you what we in the American Psychiatric Association sort of look at as the way we want to address our patients with depression. We look, if they're willing to come in for treatment, they can have that acute phase, the first 6 to 12 weeks. We hope they get a remission. We hope they get a response if they don't get a full remission, and we continue treatment. And again, the patient helps decide when and what kind of medications and what kind of counseling therapies that they have. And we try to help them along to preserve that remission. We know there's a continuation phase of that treatment, and then we try to prevent recurrence. As you see going up the triangle, we continue treatment, monitoring our patients at risk. And for those patients who've had more than 3 previous major depressive episodes, we usually recommend that they stay involved with their counseling program and stay on the antidepressant medication regimen that led them out of the episode and into recovery and remission. So then we see that there's quite a time of maintenance. And so if we just look at this again in terms of our opioid substance using patients, are we this kind? Do we allow this many sort of categories? Do we understand what chronic relapsing illness really means? Or do we get sort of impatient with them? Do we like and sometimes think that it's really a matter of, look, you're using or you're not using? And so I'm just hopeful that we understand that the opioid use disorder patients, they come from in the mild to severe illness category, just like these other chronic illnesses like depression and diabetes and hypertension. If I could have the next slide. I just want to briefly mention that in the big STAR-D studies of effectiveness for major depressive treatment, using just one SSRI as the only treatment therapy, that would be your medications like Prozac and Paxil and Zoloft and Celexa, only 37% of those patients who were given that treatment out of over 3,000 patients had a remission from their major depressive episode. Now, if you take the patients who didn't remit in that category and now give them step 2 treatment, only 30% had a remission. Take the ones in step 2 who did not remit, and only 13.7 remitted then in the next phase when we added additional medication groups or additional CBT type of talking therapies. And then if you have to go out to even more unusual antidepressants like MAOI inhibitors or combinations using second generations antipsychotics, you see that you only get 13% remission there. So again, we've come to accept this as normal and natural in our treatment of patients with depression. But I don't think we accept it as reasonable and customary when we're treating opioid use disorder patients. We should be more empathic, as the usual and customary treatments didn't work for them. We should kind of see them as special characters and maybe talk to them about, you deserve and need even more treatment. And that's why, in addition to the groups that you're going to, you may need medication-assisted treatment. You may need additional psychotropic treatment. You may need additional individual as well as group work. I'd like the next slide then. And this is just a little figure to sort of remind us again that our opioid use disorder patients are going to come in the mild, moderate, and severe category. And we need to have a system and an understanding for when they're not improving and achieving their treatment goals in the mild treatment setting, they need to go into a more intensive setting. And there will be some that will fail in that intensive setting that we have, and we will need the super intensive or specialty care. So I think we typically, when treating depression, talk to the patient about, you deserve, and I'm going to try to help you get even more specialized care. With the opioid use disorder patients, I'm afraid we often kind of say, well, you failed this treatment protocol, so we can't treat you here anymore. I would beg for more patience and more understanding. And then I'm up against my time here, and the next slides, I'm just going to go through them very briefly. In addition to the stigma, which we have to reduce, in addition to our own mindset of trying to see it as a chronic relapsing illness, if the patient we're treating has had any adverse childhood experience events, and I do think this ACE questionnaire is an excellent one and should be given to every patient who's beginning in a primary care setting. This tells you that that patient is going to already be in the moderate category. And if you look onto the next slide, I just included these so you would have them available and could. This is a primary care PTSD, again, for adults who have had, again, experiences, traumas that they didn't ask for, didn't want, but they are part of that permanent brain recording that all of us have. This has 4 straightforward questions, and then it has some nice scripting that the staff at a primary care center can use in responding to yeses on this questionnaire. I know there are some primary care centers that avoid asking these questions, and I can understand why. It can become uncomfortable. The patient can, break into tears. But again, it is important to know this about the patient so that you know what severity of illness they have with all their chronic relapsing illnesses. And then finally, the last couple slides. One more, please. This is the PTSD checklist. Rather straightforward. It's 2 pages, and I pass it to you again to use with your patients in order to ferret out when they come in and join your practice to see if they're going to be at higher risk and therefore harder to treat and therefore needing more modalities in order to help them achieve either remission from their depression or sobriety from any of their substance use disorders. So I'll stop at that and